Good evening. I'm Barkha Dutt. You're with the Mojo Story. In our preoccupation with the battle for Afghanistan, we cannot forget that there is another battle that is on in our own backyard. And I'm talking, of course, about COVID-19. There are very, very significant findings from a new study done at Delhi's Ganga Ram Hospital. And let's bring you the key findings of this study now. One of the things that is raised by this particular research paper is to ask the question, does India need to reduce the gaps between two jabs of Covishield? It was a study focused on the vaccine Covishield and its effectiveness and looked at a median gap of 30 days between the two jabs. This new study on the Delta variant and the vaccine effectiveness throws up certain conclusions that may surprise us, but may also lead us to question the current policy and the rollout and the time gap in particular. Another finding of this study is that prior infection, in other words, if you've had COVID, that almost offers better protection than 2 doses of the vaccine. What does that tell us? Will that revive the conversation around herd immunity, for instance? And the more immediate question, should India reduce the gap between 2 shots? And even if it should, can it, given the fact that we're looking at a shortage also in terms of volume and numbers? Let's bring up our panel of experts today as we look at this new survey. Dr. Vinita Bal is with us. Thank you very much, ma'am. We're also joined by Professor Veer Chauhan. And then we're joined by the 2 authors of this research paper, Dr. Ruma Satwik, who led this study at Ganga Ram Hospital, and Dr. Amrish Satwik. Welcome, all of you. Dr. Ruma Satwik, I'd like to start with you to first just explain to us, as I understand it, this was a survey of those who work at Ganga Ram, therefore frontline employees, health workers, staff. Not counting those who may have got a vaccine other than Covishield and not counting the unvaccinated. But it would be useful to understand first the number of people, the sample size, and at what stage is this only the Delta variant, for example? Go on, Dr. Ruma Satwik.
Yeah. So our study was planned in May 2021. When there were several news reports surfacing on vaccinated individuals contracting infection. And so we needed to know where the truth lies. And because one needed to know, we did know that efficacy in trials was around 70%, which would mean that there would be a small percentage who would catch infections, even after what the trial results had shown us. But to see exactly what that protection was at the middle of the surge is why we undertook this study. So we planned it as a cohort study. A cohort study is a better study design than a case control design, wherein you divide people into 3 groups, one that is fully vaccinated, one that will have received 1 dose, and the other group which has not received any doses at all. The controls are served by, you look at infection rates in the controls, and then you compare what is the reduction in infection rates within group that was fully vaccinated and within the group that was partially vaccinated. So, so a cohort study will also be as robust as its participant follow-up. So this is one strength of our study, that we followed up participants not just through hospital records, but of RT-PCR positivity, but used other means to ensure that everyone who in the cohorts who were testing positive were taken into account. That's one. Second is, we did not just take hospital-based data of hospitalized patients. We do know that there was an acute shortage of beds in Delhi at the peak of the pandemic. So even though healthcare workers included in our study have equitable access to free healthcare in the hospital, there was still a significant percentage that's about 50 of them with moderate to severe disease who were in home quarantine. So ensuring that everyone has been taken into the study is one of the strengths of our study. So what this is telling us is that when you compare 2 doses versus no dose at an appropriate interval of 14 days from the second dose, the symptomatic infection reduction would be by 28% only. So that is what is known as vaccine effectiveness, that only 28% reduction would happen in symptomatic infections. But if your endpoint is severe disease progression or deaths or need for oxygen therapy, there is a significant protection with vaccine 2 doses from there. So that's study finding 1.
Can I ask you something? Can I ask you before you come to the next finding? Was there any comparison between what happens if you extend this gap or you reduce it further? Why 30 days? Like, how did you come to this gap of 30 days between the two jabs?
Yeah. So the vaccine rollout began on the 16th of January. And the policy then was to administer doses between 4 and 6 weeks. So most people received it at 28 days. If you see the range that I have given in the study, it is 28 to 35. That's the 28 to 42. That's the average period in which most people received their second jabs. This is because of the vaccine policy that was prevalent. The study takes into account vaccination status of individuals between 16th January 2021, that is the day of vaccine rollout, to 30/4/2021. That's the vaccination status, which is why we couldn't have altered that.
Okay, and sorry, just if you want to come to, what would you say is I think what would concern people is only 28% effectiveness against symptomatic infection, but pretty decent effectiveness against death, 97%. But single dose seems to be almost, a single shot seems to be completely meaningless almost according to your survey, or am I wrong? I'll take that first to Ruma and then to Amrish. Ruma, go ahead.
Yeah. So we have to consider that we have assessed effectiveness of the vaccine at 21 days. 21 days is the period at which the primary trial told us that there would be immunoprotective effect from T cells and from B cells. So at 21 days, when we look at vaccine effectiveness, we find that it is not significant in terms of any of the outcomes. That's one. And the reason why we think that this could be happening is perhaps that while we were trying to vaccinate a large group of our people, we were caught in the middle of the surge. So looking at effectiveness at, let's say, 45 days or 50 days is something that I can't do because our study terminates on 31/5/2021. We have to take a period in which we do this. So, however, that would be like, it's a post hoc analysis. That's not what we originally set out to do. We originally set out to look at vaccine effectiveness beyond 21 days of first dose.
So let me just get Dr. Amrish Sathwik to add to this. So given that first dose, as Dr. Ruma Sathwik explained, was being tested kind of in the middle of the surge, could it be different today that you're not bang in the middle of the surge? Because what most people who are not doctors, including myself, who understand this in a very basic way, are going to look at it and say is, oh, a single shot is completely ineffectual. Whereas maybe you're not making that simplistic a point, Amrish.
Yes, I think this study has to be seen in the context of a very precipitous surge, because April and May were particularly calamitous for the city of Delhi where the study happened. And also it's looking at very specific information, which means that what is the effectiveness of 2 doses when given, let's say, when the second dose is given between 4 to 6 weeks. It's not trying to answer the question what the effectiveness is when it's given between 12 and 16 weeks, or what is the effectiveness of a single dose beyond 28 days. We need a separate study for that. But I think that the second thing is that this assumes significance because this surge was driven by the Delta variant. Now, the world is divided into the pre-Delta phase and the post-Delta phase. And most trials we had, the original trials on the Oxford AstraZeneca vaccine, were on the original grandmother wild variant virus. And therefore, we need more cohort studies on specifically on the Delta variant while a surge was underway. Because it's possible that the dynamics of transmission and effectiveness might change depending on how many people in an ecosystem or
Yeah.
a city are vaccinated when the study is conducted.
Okay, now there's one thing that's really confusing me, and then I'm sure Professor Chauhan and Dr. Vinita Bal will have more questions. And Amrish, here's my confusion. We have heard now various versions of what the gap should be between two jabs. We've heard AstraZeneca itself saying it made a mistake during the trial and thought that the gap should be longer than before. Then we've heard them amend that in the light of the Delta variant. And now we're looking at this 30-day median gap that your study looks at. If you had to if, for example, volume and numbers were not a problem, and we had to medically or scientifically say this is the ideal gap between two doses, would we know it based on this study?
No, you wouldn't. My sense is that there isn't a singular answer to this question. I think perhaps the only thing that can be said, the takeaway, would be that when you're anticipating a surge, or when you're in the middle of a surge and you have a large portion of your people who have received a single dose, then it's advantageous to perhaps advance the second dose. It would be completely different, let's say, of Denmark, where the infection rates are really low and the case positivity rate is really low. It could mean something completely different there. But if you're anticipating a surge or in the middle of a surge and you have a very large fraction of your population that has just received one dose, it might be wise to perhaps to give the second dose sooner than what the policy is. So let's be flexible there.
Yeah, I know there are lots of other questions. I do want to come back to you and Ruma, but I just want first responses, queries, thoughts on what we're hearing. Dr. Vinita Bal, I'll start with you. Another point in this study says that prior infections offer the best protection. I don't know what to draw from that, and that none of the deaths that took place. Please, Amrish and Ruma, correct me if I summarize anything incorrectly because I'm not a doctor. But that none of the deaths took place in previously infected people. How should that enhance our understanding of the virus? There have been, for example, many suggestions by people that those who've already been infected do not need the second dose, do not medically need the second dose. That's one thing I can think of straight away when I look at this finding. Vinita, please go ahead.
Yeah, there is in a way nothing novel in it because as immunologists would know, prior infection would trigger a very good immune response, whether the infection is symptomatic or asymptomatic. Depending on the viral load, there might be a little more or little less of immune response triggered as a statistical probability. But once that is triggered, and since the person has recovered, obviously there is protection which gets protective immune response which gets triggered. And if then there is an encounter with a fresh virus, it is most likely that the person concerned, the prior infected person concerned, would mount a further immune response to keep himself or herself protected from at least the disease. I wouldn't say the infection will not happen, but certainly disease would not happen. There is absolutely nothing novel, extraordinary, unusual in this. This is how we survive. So many of us actually get infected with viruses all the time, and then we are protected from the infection. If you remember your and our,
sorry, go ahead.
Your and our childhood, we used to suffer from things like chicken pox and mumps and measles, and after that we never got infection because we had naturally developed immunity. And the same logic is applicable here. It is not surprising. While the pandemic was on in the initial years, in initial months, we could not figure this out whether this is exactly would be the case. And I'm glad that there is such a big study which has come out of Ganga Ram, but the finding itself is not something that's novel as for an immunologist like me.
Okay, that is on the aspect of the prior infection. Professor Chauhan, would you, I have some other questions of some of the other findings. Professor Chauhan, do you want to just jump in, especially on the gap between the two doses and the role of the single dose in the middle of a surge?
So very quickly, first of all, I agree with Vinita, what she said, as that there's nothing greatly surprising about this. But you asked me a specific question, but I'm going to a little bit digress. I just very quickly, history of Covishield, or the brother or sister of Covishield, being produced in Belgium or elsewhere, produced in America also. as early as before Delta became known to us, there is South African virus isolated, same time when the English virus, Alpha, Beta, Gamma, we know them now. And study in South Africa, 3 studies were going side by side, Covishield, then Novavax and Johnson Johnson. They were doing all these things in parallel. And they showed very earlier on the lab neutralization assay. I'm talking about the end of last year. Already shown, and South African government then took a decision that they will not roll out Covishield or Covishield-like vaccine. That created huge amount of tension everywhere because Covishield was the vaccine of choice because of affordability, etc., all over the world. So we have very old data on Covishield. Coming to the gap, I'll put it in the Indian perspective. We have followed the data that emerged out of England, mostly from UK. And you said that AstraZeneca accepted their mistake. Actually, mistake was accepted for the half dose. By mistake, they had given half dose. Then AstraZeneca has done multiple trials in multiple centers of all kinds. They are the first one started mixing and matching of vaccine also. I'll not touch that because that's not your focus today. If we based all our policy decision or argument, scientific or otherwise, based on what came out from England, for example, I don't think we have a phase 3 data, large data trial done in India, or you have the data. We depending on the data which came from England. So one variable which I think Satvik hasn't, Ganga Ram hasn't, they've said it in the paper, but it's not in our discussion that the pandemic at that time surge was probably at least half of it driven by Delta virus. Probably, because there's no hard data, but by that time I said Delta was certainly, and today of course if this discussion is relevant for today, be rest assured there's a huge amount of Delta now. England long back when India just increased the gap it got back to rest of the world. The Delta one dose, single dose for a short period doesn't protect you, went back to 6 weeks, just as when we were changing our policy for a longer dose. When Boris Johnson had initially problem of a huge surge in England, they said maybe with 1 dose we'll cover larger number of people. That was the problem at that given time. They got over that problem, and it is now policy in England that the dose difference between 1 and 2 doses is 6 weeks or 1 month or 6 weeks. I'll tell you, I'll just close this because I can go on. The NIH has said for all vaccines of all kinds, you must not change at all from the data that you submitted to us. Moderna, X days, Pfizer, X days, Johnson Johnson single dose. And it's no surprise to me that Covishield vaccine is yet not approved in USA. As a single dose, double dose, gap, so this Covishield story is amazing because this is the largest single vaccine that is rolled out in largest number of countries. Yet it comes out with one controversy or the other almost all the time. I think if you follow the data that is coming against the Delta virus, you really should consider to reduce the gap.
Okay. Okay. Let me just get Ruma and Amrish to come in on this. Would you advocate reducing the gap, Dr. Ruma Satvik? I'll start with you. Does your study nudge you in that direction? And does it also nudge you in the direction, not that anyone's going to follow this, that someone who's been infected should not get a second dose? And the reason nobody will follow it is because people will worry, they'll be apprehensive, and they'll also, a certain class will worry about not being able to get onto a plane again, and so on. Ruma, go ahead.
Yeah. For now, if you, like it has already been stated in your program just now, that if you anticipate a surge, or if you think that the infection, you keep an eye on the numbers, and you think that the numbers are beginning to rise and that they're going to peak very soon, it is best to follow a policy of shortened intervals, 28, 30, 32, as quickly as possible, because 2 doses will provide decent protection against all outcomes. 1 dose may not provide that infection. So if you want people protected, vaccinate them more as quickly as you can, especially when you're anticipating a surge. But if, let's say, the thing has been pretty steady, your infection rates, test positivity rate has been very steady at what it is like in Delhi right now, but it's very difficult to actually predict if there would be a surge by October or November. But if it has been very steady, it's all right to wait longer, especially if there are acute shortages.
My question, Dr. Amrish Satvik, would then be that there is no perfect science to anticipate a surge. Like, for example, there's been so many dates given for this third wave. So let's take a look at the states right now that are experiencing that rising graph. Let's pick up a Kerala, for example, which actually has decent vaccination protection. How do you apply the findings of what you saw during this April-May surge to a state like Kerala? What for you is the most important takeaway from your survey? Sorry, you're on mute, Amrish.
Am I audible now?
Yes, please.
Right. So, first of all, I think I'm going to also say something sacrilegious, but we should come back to the first salient finding of the study. That's the protection offered by 2 doses at this interval is also 28%. That's very modest. Okay. What that also means is that the vaccines are not doing too much to prevent you from getting infected symptomatically, or as we are realizing from other studies done elsewhere, that the vaccines are not stopping transmissibility of the virus. So you are not only is it possible that one might get infected symptomatically, even though one is twice vaccinated, but one can also pass it on to others. It also, so therefore, the sacrilegious bit is that vaccine passports might not actually mean too much. Right, because...
So hang on. I want you to explain what you've just said, because my understanding was that vaccines will mostly, 2 jabs will protect you from deaths and hospitalization, something that your study bears out, right? Maybe they're not doing too much against symptomatic infections, which is the point. But please correct me if I'm wrong, because again, I've seen contradictory information on this, that vaccines, while not being a guarantee against transmissibility, do bring it down. Are you finding in your study that that's not the case, Amrish?
Well, we haven't specifically looked for transmissibility. We have some data on infections and family members, and we can do a follow-up on that. But definitely there are studies from multiple centers that are coming in, which are saying that vaccines are not doing too much to stop transmissibility. A fully vaccinated individual can pass on the virus to others. Even the CT count in the throats and noses of those doubly vaccinated is not particularly different from those who are unvaccinated. So what that means is that if vaccines are not giving you very good protection against symptomatic infection, and they're not doing very well on the transmissibility factor, therefore, if you give out the message that it's perfectly fine for you to be sanguine and complacent when you're doubly vaccinated, like the CDC had asked for a removal of the mask mandate, Israel had asked for a removal of the mask mandate when you're doubly vaccinated, you suddenly allow doubly vaccinated individuals to go into malls and cinema halls to the exclusion of others, or that's the principle of the vaccine passport. That might be problematic, because it's not how these vaccines in their current form are working. If you wish to get there, we might need to tweak the current vaccines we have.
Okay, that's interesting. Let me get Vinita and Veer Chauhan to respond to that. Dr. Vinita, well, go ahead. What might that also mean for policy? Because our cities are open. Other than our schools, our cities are now fully open. Our cinema halls are open as well.
Yes. It's perfectly right that none of the current vaccines in use stop transmission from one individual to other. So there are transmission blocking vaccines in principle which are not in use, and the other category is what is currently in use. Transmission blocking vaccines are very difficult, not just to develop actually, but to be effective, especially in countries like ours, because we somehow seem to have what we call poor mucosal immune responses. So our gut responses to vaccine are poor, our nasal responses to vaccines are poor. This is something that we have seen very much for other vaccines. So in India, transmission blocking vaccines would be even more difficult to get. But what Dr. Satvik was saying is absolutely right. Current vaccines are not transmission blocking vaccines, and hence, even after complete vaccination course plus 15 days, there would be still infection that is possible. And that is why we keep saying that the physical distancing and masking is something that we cannot let go, and that needs to be done. So in that sense, what CDC and other people, other institutions recommended, and I agree with him that that was sort of premature, or they were taking calculated risk, if one can call it that. But that is something that will become easier if you have, say, 90%, 95% vaccine, two shot or whatever appropriate shots of the vaccines are already given. Because even if the infection gets transmitted, which it will, despite vaccination, none of the people who are vaccinated are likely to be really admitted to ICU, need oxygen, have serious disease. This is something that their data also shows. And there have been reports which say immunologically, it also depends on the level of antibody. Miles Davenport is the last author of a Nature Medicine paper, which that paper actually shows that if you want asymptomatic infection blocked, you need maximum possible antibody. If you need to have ICU stoppage, entry into ICU stoppage, you can do with less antibody. I mean, all that you can see, it may look like reverse logic, but that logic is very clearly stated in that. So asymptomatic infection stoppage will require a lot of antibody. And because these vaccines give us a certain level of antibody, we can decrease, the vaccinations would decrease severe disease and hospitalization.
So
that's what their data also shows.
So let me also say something sacrilegious to Professor, or ask Professor V. Chauhan with a sacrilegious thought, which has long been my thought. Despite having COVID, despite losing my father to COVID, I continue to think that the world doesn't have too many options here. I continue to believe that the options are not, too many. And therefore, other than these vaccines, even if we find that, these two vaccines together don't actually reduce transmissibility, and yes, other than promoting mask wearing and all of that, what are the choices? Then we'll be back to some conversation about either herd immunity, or we'll be back to some conversation about learning to live with the virus. We'll live in the hope that the pandemic will become an endemic instead of a pandemic. I mean, what are the choices? Because people listening to this will just get demoralized and say, oh, the vaccines don't do too much.
So I'll just take a step backward. And I think what Satvik has suggested, if that is taken further to its logical conclusion, would be a dodgy proposition. And I think this is dodgy because we just haven't got very many studies done and not large enough. But let me say this to you and to your viewer. None of the vaccine ever promised that they will talk about transmissibility at all. The vaccines promised only one thing: they'll save you from dying, save you from going to ICU and so on. And none of the vaccines have claimed anymore. It's just that scientists have done many more studies, and data varies from the present study that you see to 66%, depending on which vaccine and so on and so forth. I think take-home message should be the vaccines are desperately important. We need to get vaccinated. If you have exposure, we don't know what was the load of a virus. We're not going to test everybody. Do you have enough neutralizing antibodies or not? If you can access a vaccine, my own view would be, my personal view is, get vaccinated. It protects you from death. This study says the same thing. So I don't see any change in that, because vaccine never promised that you will not get asymptomatic, you will not spread the virus. I don't think this is the right time to blame or to congratulate a vaccine. That, oh, come on, you don't do any transmission reduction, why should we bother? We should bother because they protect you from dying. They protect you from death. And that's it. Let many more studies emerge like this. And then let people take call. I would be a little bit skeptical about saying that, oh, you have an exposure, you don't need any vaccine. I would worry about that proposition.
Okay, let's get responses, quick responses to that at the end. Ruma, do you want to go first? I mean, I don't think you're promoting vaccine hesitancy, but to this point that vaccine passports may not be all that they're cut out to be, that Amrish made, I would still say, what's the alternative? What's the option?
Yeah. I would think that vaccines are evolving, as is the virus, but they should be a vaccine which will have greater effectiveness than the current lot. So since the virus has mutated and is the Delta is the predominant variant across the world, we should soon have a vaccine which will be more effective against the Delta. But that said, I agree with Professor Virendra here that if it is deaths and serious disease that one is talking about, personal protection, and with what Dr. Vinita said, that a greater number and percentage of people being vaccinated. So even with transmissibility, it's personal protection which should improve greatly.
Yeah. Amrish, last word, got to close. You're on mute.
Yeah. Right. I'm in complete agreement with what everyone has been speaking about. In fact, what I said earlier was not to take away from the felicitous nature of vaccines. I think we are not litigating on the need for vaccination. I think these vaccines are doing a wonderful job as regards preventing severe disease and death. I'm making a very specific point, and this point is important from a public health perspective because it will determine messaging in the community. I think the fundamental reason COVID has spread so widely is because it exploits a certain quirk of human psychology. And that quirk is that breaking physical distancing rules seems less risky when you're doing it with someone you know. Most infections happen in a situation where you're without your mask, and that happens only when you're with people you know, at your workplace or with friends and other places. If you're fully masked up in a marketplace, you're unlikely to get infected. So you have to communicate that these vaccines are extremely important because they're preventing you from getting severe disease, landing up in the ICU and dying, but they're not necessarily doing a very great job of preventing you from getting infected. That's all I'm trying to say. And therefore, you mustn't be sanguine, because what happens is that if you suddenly say that people who are doubly vaccinated, it's fine for them to do anything, and the others, no, they have to be careful. That's the wrong message that's going out. So it's messaging as regards what a public health expert would advise. So you shouldn't be sanguine just because you've had 2 shots.
Okay, we leave it there. I think the old rules still apply. Even if you've been vaccinated, wear your mask, don't go into indoor crowded areas, look for good ventilation. These are all important inputs, especially because the most important thing that should have opened, it remains a big bugbear of mine, schools. I think we're not talking about that enough. How will all of these data points impact that? But thank you. All data points are important. It is an evolving situation. It isn't the end game yet. And I think that's what's important to know. I think, as was said, both the virus and the vaccines are evolving. Thank you, Professor Chauhan, Dr. Bal, Dr. Amrish Satwik, and Ruma Satwik. Very sort of interesting conversation, but at the moment, the priority has to be to get the maximum number of Indians vaccinated. That still has to be top of the agenda. Thank you very much for watching. And if you haven't got your vaccine and you have access to one, please do get your shot. Thank you and see you soon. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.